All right, good morning, guys. Yeah, so I'm giving the CCM lecture today. It's a 94-year-old female complaining of shortness of breath. It's the chief complaint. Thanks to the CCM team, Dr. Belyovska, Dr. Tan, Beta Kim D'Souza for their edits and help. So we'll just kind of get right into the case. This is a patient that came to downstate. The chief complaint at RN triage was difficulty breathing, and the physical exam that was documented was within normal limits, in quotation marks, as you'll see. So the initial set of vital signs significant for this tachycardia, but the rest are grossly within normal limits, maybe some mild tachypnea. She gets placed on a monitor and is just kind of like resting in a room. When you start hearing some like alarm bells go off, it's beeping, patient, well, you're alerted by one of the nurses, hey, like patient looks very dyspneic, they're a little bit agitated, more tachypnic. So you go over and you see the sat that's like 77 on room air with like a waveform. And then you look on the monitor and you see this kind of like strip. Can one of the juniors sort of like really quickly identify what you see? Speak up. Just like simple stuff, like, is it fast? Is it slow? Is it wide? Is it narrow? Regular? Is it irregular? Yeah, nice. Yeah, so it's this irregular, fast, wide rhythm, basically. But there's no variability in the RVR. So you recognize this, and yeah, we'll go from there pretty quickly. So your initial assessment of this patient, they're having some garbled speech, but the airway is intact. The patient has diffuse rales on auscultation, is tachypnic. In terms of circulation, they're tachycardic with cool extremities. Otherwise, their ANO times 1. So given this kind of like primary survey, their vital signs, and this rhythm strip that Max kind of identified, what are the first set of problems that you identified so far? Okay. Yeah, hypoxia, this rhythm, AMS. Anything else? Possibly, yeah. So pretty much hit most of the main kind of things. Patients tachypnic, they're hypoxemic, and they have this like rhythm that's fast and wide. So initial interventions, what do you all want to do? They're on a monitor, so that's good. Yeah. Anything else? You hear some rails, they're hypoxic. Yeah, ultrasound on the monitor. Yeah, it's a good thought too. 12 lead, yeah. Pretty much most of those things, yeah. So supplemental oxygenation, patients they're already on a monitor. You get IV access started, send labs, you do bedside ultrasound, get an EKG, and then blood gas. So this is the ultrasound that you perform, and you see this in both lung fields, so confluent V lines bilaterally. You do an echo. It's for this patient, it's not as bad as this, but it's a reduced ejection fraction. On their like bedside echo, in the documentation, there's no right ventricular dilatation, and the IVC is actually mildly collapsed. So that's kind of like your general assessment. And so on reassessment, right, patient's agitated, they're placed on a non-room breather. They're taking the mask off, but they're redirectable by the daughter verbally. When you look at the monitor, the patient is intermittently going through like just kind of runs of different rhythms. So sinus tach, AFib versus A-flutter. This heart rate's going up to like the 180s essentially. The blood pressure is reading this like hypertensive kind of like figure. The diastolic's a little bit high, but in general, like the patient's tachypnic, and the stats improved from what it was before. And so in terms of the ED course, the patient receives IV push of Diltiazem, and you actually get this blood pressure and heart rate. Same patient. Yeah. Yeah, interesting. So somewhat improved in the hemodynamics, potentially. We'll reassess. So in terms of the HPI, you get some story from the niece as the patient's a little more agitated and in distress. And so she's been short of breath acutely for the last day. At 3 p.m., she was noted to be tachypnic and it was kind of complaining of this like suffocating feeling. And the niece is an RN, so she checked a pulse ox. It was on the low side, and she called EMS to bring her into the hospital. Otherwise, initially they're saying like she was in her usual state of health. When you talk to other families, well, they kind of indicate that there's been some weight loss, maybe some dyspnea, some fatigue, some decreased PO intake, but no chest pain. They don't notice any kind of bleeding anywhere, no trauma. She didn't hit her head, and no like infectious kind of like symptoms really. Has a history of hypertension and diabetes, is on aspirin, topical amlodipine, no allergies. And then we'll go into the physical exam for this patient. So patient is ill appearing and moderate distress, moaning. On heat exam, no significant pallor is appreciated. They're atraumatic. Patient's tachypnic as identified earlier, rales in the lower lung fields, shallow breathing. They're tachycardic, there's no murmurs. She's moving around a little bit too much, so it's a little bit hard to appreciate JVP. There's no comment on any pulses for her, like distal pulses and whatnot. Her abdomen is soft and non-tender. And then on extremity exam, she is cool to touch, but has brisk cap refill, and there's no pitting edema. And then lastly, her neurological assessment, she's following simple commands in Creole, but she's anode times 1/2, moving all extremities kind of like independently, autonomously. At some point around now, you get a venous blood gas that's back. And so we'll have someone kind of interpret this blood gas and the findings. Yeah. Yeah, pretty much it, most of those things. And then the bicarbonate and BNP is about like 16. So there's also like a metabolic acidosis that's going on. It's a mixed picture. There's no compensation for like the primary respiratory acidosis that's happening, but you do see this elevated lactate and this hematocrit's a little bit low. So the next step really was to order some blood, since there was some concern maybe that is this contributing as well to the patient being, in decompensation. So blood is ordered for the patient. And eventually, once the patient is a little bit more stable, this EKG is obtained for the patient. This was obtained after the initial resuscitation. So a little bit on the delayed side, but you had to kind of like stabilize things, establish IV access, improved worker breathing, et cetera. What do you guys see? Just like shout out the diagnosis. I would say it's normal sinus rhythm, actually. You see P waves, V5, and 2 as well in rhythm. Yeah, so it's a left bundle branch block. If you look at V3 and V4 specifically, it might give you more of an idea. So this patient actually meets Scarbosa criteria. If you zoom in on V4, that's concord and ST elevation, 1 millimeter. And V3 meets modified Scarbosa, where the R to S ratio is more than 25%. So this patient actually meets criteria for an MI, basically. So at this point, you have like a bunch of different things that diagnostically give you an idea about what's going on. So your differential diagnosis for this patient. Yeah. Sure, yeah. Anemia of some sort. They're in like a rapid rhythm as well. I think John mentioned cardiogenic shock earlier too. It's a good thing on the differential as well, just because lactate's a little bit elevated, a little bit cool, right? They have this reduced EF also. Getting most of it. Yeah, is there like GI bleed happening as well? The IVC was collapsed earlier. Because this patient had COVID, right? Along with all these things, bilateral B lines. More confident here that it's a possibility, obviously with the dyspnea. There's this like weight loss, kind of like this fatigue over the course of months. Is this COVID plus a PE possibly? We didn't see like right heart strain, but something to consider given that they were pretty hypoxic. A little less likely with the rails, and then they do have like an elevated anion gap, and then the lactate's high. So something metabolic happening too. So pretty wide differential, but I think like we've covered kind of like most of the essentials. And so with all these ideas in mind, anything else that you guys want on labs? Yes. Mm-hmm. Yeah. Yeah. So these are like the tests that are ordered, kind of like a basic set of labs, cardiac enzymes, COVID, X-ray. At this point, the patient's heart rate kind of like starts to go back up into like the 120 to 180, kind of like that range again, where they're going really fast. And I guess now, because like you have this concern for like an MI, you maybe are thinking about, oh, like this patient's in heart failure, right? Like maybe we shouldn't give a calcium channel blocker. Someone maybe told you that at some point. But you know, the rate's kind of high. It's pretty fast. And so I think you should do something about it. So what ends up happening here is that the team initiated an Esmolol drip. And then the two blood pressures that I've listed here. So the first one is like within like 15 minutes after it was started. So the patient was already in like the 160s, the 170s, tachycardia, and then the drip started and the BP goes down actually. Sorry, the heart rate comes down, BP comes down a little bit. And then the second blood pressure is actually a reading about like an hour afterwards. So it's maintained rate. The patient's fairly comfortable actually at this point, more comfortable than they were when they first came in. They have a unit of blood that was ordered and it's kind of being given to this patient. At this point, you have results coming in. Hemoglobin is 9.2, not as bad as the 14 that was on the shock. You see that they have a bicarb of 16, BUN is elevated, creatinine is a little bit elevated. We don't know if they have CKD at baseline, but those are kind of like those labs. Chest X-ray shows pulmonary venous congestion, maybe some cardiomegaly, some effusions. Radiology obviously says you can't exclude a pneumonia, clinically correlate. And then test of the day, right? So this is your troponin I, which comes back 37.5. I guess not, yeah. Yeah, the BNP is elevated as well. Your COVID's negative. So cardiology is consulted after the troponin. And so your updated problem list includes myocardial infarction, right? Your patient's in rapid AFib. They also have pulmonary congestion. They're experiencing heart failure with a reduced ejection fraction. There's also like a possible AKI component to this. Cardiology comes down. Their impression is this is like an NSTEMI with new onset AFib with RVR and heart failure as well. They actually do want to admit the patient to CCU. So they recommended no cath for this patient. Their documentation is that the risks outweighs the benefit in the setting of AKI and then metabolic acidosis. To be honest, it's not that much for metabolic acidosis, but yeah. I think the better discussion would have been like, is this something that would be in alignment with patients and the family's goals of care, but that wasn't like really dictated. They recommend dual antiplatelet therapy, starting a heparin drip, no bolus. Keep up with the Esmolol since it seems to be working to control the rate appropriately. They recommend giving this patient who actually is not really hypervolemic Lasix 80 milligrams. And then they recommend getting an ABG and a D-dimer, which thankfully the dimer was never really sent. And so your final diagnosis really is kind of like these three things that are happening, kind of coexisting, but also happening independently too. Maybe one happened first and kind of push the cascade forward. But my talk today would focus kind of mostly on like the top two, really. It's a little bit specific, but I think these are some of the more difficult patients that I've had the luxury of managing. And I think it's just because the literature is not really as developed into managing these patients, because you don't really want to, yeah, like most of it's about managing rapid AFib in a patient with a healthy heart or like pretty much preserved ejection fraction. So I was really curious, like, you know, is there anything else that we could do differently? Are there different approaches? Maybe I can reconsider what I've been taught or like what I like reflexively think about doing. And so that was kind of like the impetus for doing this talk. And so the discussion will mostly be focused on understanding like the physiology and pathophysiology, because I think when you really understand the mechanisms, they should help guide you during your resuscitation. We'll discuss hemodynamics and, you know, the question of, you know, does this patient warrant intervention on their heart rate because, is this really AFib that's driving instability, or is it just kind of like a bystander that's going on for the ride, but something else is happening that's leading, this patient to be unstable. And then we'll kind of like think about the evidence base that exists for rate control, reevaluate kind of like the dogmatic practices and ideas that have been pushed forward. I won't be discussing rate versus rhythm control. This has already been kind of like, talked about ad nauseum. There was an EM controversy that was done last year. You can go on the YouTube and it's actually a pretty good talk. The essence is that, rhythm offers no specific advantage and there's many adverse effects from like the medications themselves. But you guys can kind of like refer to that talk for like the more specific details on the trials and whatnot. And then the big sort of like, difficulty really is that most available studies are centered on, how do you manage stable patients with rapid AFib? How do you manage rapid AFib in the setting of a preserved ejection fraction? So there's no real RCT data on the subject of how to manage unstable patients with reduced EF. So we'll start with pathophysiology first. So we'll go over kind of like just AFib, how it begets itself. We'll talk about diastolic function and then wrap it up with a discussion of kind of the downstream effects of both these things kind of happening at the same time. The broad strokes idea about AFib is that, it's the heart needs to have a propensity towards, dysregulated conduction, and there needs to subsequently be some kind of stress or rhythmogenic trigger that ignites, the flames and promotes this perpetual, AFib from happening, right? So you need both a substrate and a trigger at the same time. The general consensus amongst like various cardiologists and EP folks is that like it's somewhat of a two-step process where sustained AFib, you need to have this substrate that forms that just really wants to like fibrillate. And then the substrate really, it occurs through the development of like atrial fibrosis that occurs, which in general is typically like a chronic subacute process, but it can also happen in like the acute setting. So obviously your patients with chronic hypertension, valvular disease, right? Untreated thyroid disorder, et cetera. But also your acute processes, right? Like an acute MI that happens, your patient that's, having severe sepsis or septic shock. All these things kind of lend itself towards like a common inflammatory pathway. You activate like your RAS systems, you generate all these like free radicals, and what happens is that sort of like re-engineers, damages like the atria, and you have this substrate that forms. And then afterwards, you need some kind of seed that initiates this AFib. Now that you have this, substrate that is wanting to go into atrial fibrillation. And so something like a persistent tachycardia can really prime the conduction system to go into AFib. And what it does is that it produces this like electrical remodeling that, lends itself susceptible for AFib to occur. And a lot of like intracellular changes, different expressions in like your mRNA and like your genes, all these things are happening. And then you have AFib that kind of like happens and kind of perpetuates itself. We're obviously always thinking about what is going on that's triggering this AFib that's occurring, right? It's obviously like multiple factors that perturb like your normal electrical conduction systems. And so hypokalemia, hypomagnesemia, hypovolemia, right? Any alterations in like the sympathetic or parasympathetic activity that's occurring. Anything in general that's leading your atrial foci to develop abnormal automaticity, you're self-sustaining these action potentials and reentrant circuits. This is what creates this rhythm that's unstable, basically, or difficult to treat for that matter. And so the downstream effect is that you arrive at this point where you have various comorbidities that shape this patient into becoming kind of like this like substrate, a lot of neurohormonal changes that occur, right? A lot of structural and electrophysiological alterations that create this milieu where you have both AFib that happens and also heart failure that happens. And this could be independent, or it could be something that's concomitant at the same time because one mechanism promotes the other essentially. And so like now that we have this kind of like wordy understanding of how AFib, forms and works, I think we can better appreciate how it compromises like a strained or diseased heart. And that's what leads to, these patients and their presentations that we commonly see in this community with, very significant hypertensive heart failure, significant cardiomyopathy from uncontrolled tachydysrhythmias. We're very familiar with this curve from medical school, right? You kind of understand the S1, the S2, how to correlate the curve with like the EKG itself. And so the talk will be kind of focusing more on diastole rather than systole, because diastole is what's more acutely impacted by like a rapid rhythm like this. And it's where our intervention in the ER can have a lot of impact actually for this specific type of patient. And so in your cardiac cycle with diastole, the idea is that diastole occurs to adequately fill the left ventricle with enough blood at a low enough pressure where you're having enough flow forwards eventually, and then you also don't want flow to go back to form congestion, right? There's 4 parts to diastole. The first one is this isovolumetric relaxation, where essentially this is the stage where the aortic valve closes before the mitral valve opens. And you see in this graph where the pressure in the LV, it starts to rapidly decrease without any change in the volume. But at some point, the pressure goes below the pressure in the left atrium. And that's what allows for the mitral valve to open, and you get this rapid filling that occurs. So that's the early filling or stage 2. And so it's passive filling that occurs into the left ventricle. This accounts for about 70 to 80% of all the volume, which ends up being like the end diastolic volume in the LV. At some point, once the pressures equilibrate, you get to this third stage called diastasis, where you no longer have passive flow. And then you have your last stage, which atrial systole or the atrial kick, which produces this like second quick pressure gradient between the chambers. So you kind of like push the last 20 to 30% of blood into the left ventricle. And this atrial kick, right, it's really important. It's the force that's generated by, the atria contracting. And this augmentation of LV filling occurs with normal coordination of the atria with normal contractility. And this is lost in AFib, especially at a rapid rate, since there's no coordinated atrial contraction that's occurring. And so what you get is like a lot of diminished filling of your left ventricle, a reduced cardiac output. And since the atrial kick contributes to like almost 30% of like the possible end diastolic volume, people who are sick, who have diseased hearts, like they're going to be more susceptible to like decompensating. A person who's healthy, who's normal, like they can deal with like this 80% blood kind of like going through because their physiology can match, what's going on. But if you're tachycardic, you have reduced time for like ventricular diastole, and so your filling is more dependent on this kick. And so if your ventricle is more stiff, you're not relaxing as much, you have diastolic dysfunction, and you have this like early diastasis, you become very dependent on this kick, and it leads to this like really bad cycle of disease basically. And so when your heart rate rises, right, diastole is much more impacted, and so you get this impairment in like the myocardial perfusion and filling. Just like a quick discussion of the diastolic filling. The first one, so that's your E wave and your A wave, obviously, as listed there. In figure A, you have what happens with AFib, where like your A wave with the A kick is kind of like, lost. And because you're in rapid rhythm or at a rapid rate, your diastolic time decreases much more dramatically than your systolic time. And your cardiac cycle and your heart failure patients in particular, there's a prolongation of your systolic time. And so you have this abnormal shortening of your left ventricle in diastole. And so you get this reversal of systole and diastole, this ratio, and that compromises the filling of your heart and also compromises the function. And this mismatch is accentuated during stress states, whether it's exercise or critical illness. And because of this, you have impaired myocardial perfusion and impaired kind of like cardiac output as well. So that's what happens there. So your A wave in diastole is lost in AFib or in like your rapid rates, and then your filling basically is dominated by this early E wave that happens. More specifically, you have this acceleration time that's kind of listed as this AT measure, and you have kind of the dots going towards like the peak of that velocity curve. And so your acceleration time actually is kind of like fixed between like 80 to 100 milliseconds. And this is independent of how stiff or how hypertrophy your left ventricle is. And so they've actually done some calculations that show like an upper limit of normal for like a safe heart rate, somewhere around like 166 beats per minute. But, this is obviously dependent on different patients, their physiology, how their heart kind of works in general. But that's maybe like the upper limit of normal of what like a heart can kind of tolerate before it kind of can't really keep up with like the cardiac output and stuff. And so that's like the A wave being lost in AFib. And then what you end up getting is just like, if figure B is your EDV essentially, because you don't have like an A wave and there's not much time because of the tachycardia. And so that's just all that you have. Obviously your deceleration time, which is the DT, is also very important contributor to filling. And here, this varies a lot depending on like how much diastolic dysfunction you have. And they've actually found that with your grade 1 diastolic dysfunction, this time is actually extended more compared to your grade 4 diastolic dysfunction. And so what ends up happening is that in grade 1 diastolic dysfunction, you need like a longer E wave to fill. And so you need like a longer time or a slower heart rate to fully fill. And so you get this phenomenon where, you know, you need more time to fill the ventricle, but you're also losing this A wave. And then you go into a rapid rhythm. And so like both of these parts are kind of like really messed up. And then your patient then decompensates and spirals basically. In general, what ends up happening is that, you know, your stroke volume, right, which is related to your cardiac output, right, it's very dependent on the end diastolic volume, but, you know, there are other factors that also go into play, right? Like your preload, your afterload, contractility, how the valves function. And so, you know, your cardiac output's dynamic and dependent on all these kind of like variables, you know, occurring at once. But so your AFib patients at rest, you know, they need to maintain their cardiac output by increasing their heart rate because they lack this atrial kick. And what they found in like a lot of physiologic studies and also like Doppler studies on patients who have AFib that are getting these kind of like stress tests is that even when you kind of like increase like the stress or increase the exercise tolerance and you look for this heart rate to respond during stress, this elevated heart rate's not really enough to keep the cardiac output and the exercise tolerance to be normal at peak intensity or at peak stress. And so this is kind of what happens when your patient is also in decompensated heart failure too, because you're not really having like an appropriate stroke volume. You're not really having an appropriate cardiac output. And so they've done plenty of studies that show, you know, there's greater association with morbidity, mortality. These patients then get admitted more frequently, obviously, and they just kind of keep coming back to the hospital because it's really hard to optimize this hemodynamic kind of setting. And so at some point, you know, if you have enough myocyte trauma injury, this also serves as a trigger to push, you know, an arrhythmogenic atria into AFib as well. And so a lot of research shows that, you know, the incidence of AFib and ACS is actually quite high. And it increases with age and also with the severity of the MI. So larger infarct territory, higher propensity for the patient to develop like AFib. It's fairly common in the peri-infarction period as well. And then this development of AFib increases the 30-day and long-term mortality pretty significantly. The most common mechanism for AFib to occur during like an MI, essentially is because the atria are very stretched from elevated pressures, secondary to heart failure. You can also get atrial ischemia from like, you know, infarction, ischemia to the SA and AV node that like then ignite this AFib pathway from occurring. But in general, you know, because AFib reduces the diastolic time for perfusion, you also get reduced coronary perfusion. And so because coronary flow is mostly diastolic, this, you know, prolonged period of like deep perfusion leads to, you know, subendocardial ischemia, which then leads to epicardial ischemia, and then you get LV dysfunction. So obviously for these patients, they need revascularization to help prevent their arrhythmia from kind of like degenerating as well. And you want to reperfuse anything that's salvageable with the myocardium to prevent any kind of established scar tissue from happening, because that's going to just create like a nidus of reentry that keeps going on and on and on. And so, yeah, these patients are very dependent on their heart rate, but they really don't have, you know, their stroke volume is pretty fixed too at the same time because of like just their physiology from like this diseased left ventricle. And so it's really difficult to kind of optimize this heart rate. And so their risk of mortality, the risk of dying is like quite high. In our case here, you know, the patient had an MI, and so that likely had some, you know, it played some factor in predisposing this fib and flutter. But I think that we also see a lot in this community is people who have AFib that's been ongoing for a long time, hasn't really been diagnosed. They're maybe minimally symptomatic to start off with. And for her, you know, she's having this kind of like month to few months kind of like decline that's subacute with like this fatigue, this PO intake that's reduced, right? She's more tired at home. And so maybe she was actually in AFib at some point, like persistently or like getting paroxysms. And at some point, it's possible that she just went into like a rapid fib or flutter, and that's what prompted this MI to happen. And so having the MI might have just been like the acute trigger for both things to happen at the same time. But then so she went into this decompensated heart failure. And so you get this concept of like a tachyarrhythmia-induced cardiomyopathy. And the most common sort of etiologies are SVT and like chronic AFib, actually. And you can also get, if you have like frequent ectopy with like a lot of PVCs, like significant burden, that can also predispose you to developing like this type of cardiomyopathy or heart failure too. And really the management for these types of patients is you want to like do either rate or rhythm control. People who have AFib that's chronic might benefit from ablation, but the big takeaway here is that this is reversible, where once you kind of like get the rate controlled to a degree, the patient's cardiac function, their LV dysfunction actually resolves over the course of months. And so these are types of patients where like you might need to be a little bit more aggressive in starting rate control or rhythm control. Obviously, many different things go into the consideration of what agents you start and how you want to go about doing this. Cardiology should be involved in this decision-making process as well. But this is something that you should always kind of keep in mind too, because this is like a reversible etiology for heart failure. In this chronic tachycardia, right, it's leading to like just activation of all these neurohormonal like, agents and pathways. And so the quicker you get to like sort of stopping this from happening, the faster your patient recovers. And so I think this model kind of like, is fairly comprehensive in understanding how this patient sort of deteriorated, right? As we kind of discussed, the heart failure is multifactorial. It's ischemia driven, but also maybe AFib has been kind of going on for a while, right? And the patient is pushed into a rapid rate, but then you get the cycle of diastolic dysfunction, increased LV pressures, heart failure, cardiac output being diminished, AFib, et cetera, et cetera, et cetera. What I think is also important to kind of discuss here is that giving this patient Lasix might not really be super helpful, since this patient seemed to respond pretty well to like rate control. And so here you kind of see that there's some rate-related congestion that's occurring. And given that the IVC was collapsed, they're not really hypervolemic, right? They don't have like pitting edema. They're not like anasarchic. It's just kind of like this congestion. Lasix might not really be helpful. It's interesting because maybe almost half of your patients who are in decompensated heart failure, they're actually depleted intravascularly. So I would actually encourage everyone to do an IVC sono on all these patients, because you'd be surprised, because some of these patients might actually need a little bit of volume, depending on what their EF is, because that might actually optimize them a little bit better. And so diuresis here might not actually exacerbate the hypotension, or, since you're reducing preload, especially if you're doing rate control, that's kind of like impacting the hemodynamics. Maybe don't consider diuresing them like in that acute setting. Maybe do that like much later on in their course. And so I think like for this patient here, right, the question is like, she's going pretty fast, and she's definitely unstable because she's pretty hypoxic. She's having ischemia as well, right? The question about how you handle AFib, and I think this is always a little bit tricky because it's not always so clear cut, right? The patient being like very tachycardic, very hypotensive, you shock them. You always want to look for like a underlying etiology that's causing this patient to go into like rapid rhythm. But you should always kind of like center this question around whether or not, the AFib is causing the instability, or is it something else that's happening? And so there are a couple of different things you can always sort of like think about. So one thing being like, what the heart rate is. If the heart rate's like above 150 and it's like kind of like even higher than that, then you can think about maybe the rates actually also contribute to this instability. If it's less than 150, especially if the patient has chronic AFib and they're going this like 130 to 150 range, chances are that's more likely their sinus tachycardia. And so you should look for other underlying causes that are going on and kind of address those things as they come forward. The one caveat is, if your patient has rapid AFib, the heart rate's greater than 200 and they're wide and irregular, that's WPW most likely. And so, you address that in a different way. But typically the heart rate can give you a little bit of a clue as well. And also kind of like their past medical history as well. And then lastly, if they have any sort of other cardiac problems that are underlying, this part's a little bit difficult because like a lot of our patients don't really have that prior echo. They're coming in like for the first time to see a doctor in like decades, maybe the first time in their life. And so you can't really say that they have a structurally okay heart, but if you do have prior echoes that kind of demonstrate like this person has pulmonary hypertension, they have mitral stenosis, they have significant aortic stenosis. These are conditions to be more mindful of, because those are conditions where the patient really needs the atrial kick. And so if they go into like a rapid AFib, you should be more kind of aggressive about shocking or controlling that rhythm or that rate. Because if they don't have that kick to kind of like, augment their cardiac output, they're going to decompensate very, very quickly. Pulmonary hypertension patients also in particular. It's the same kind of like phenomenon here. Since it's very deleterious to reduce kind of like the duration of diastole, since that diminishes the flow, the filling across these valves, and then also you need more time for like the atria to also kick and perpetuate the blood into the ventricle too. So you should always kind of be thinking like, what's driving the instability? Is it the AFib or is it something else? So always have that question with you when you're seeing this patient. Because there are quite a few harms associated with rate controlling patients when they don't need to be rate controlled. This first one is like a study that was published in Annals in 2015 by this group out of Canada. And it was actually this retrospective analysis from 2 separate EDs. And these patients all had something else concurrent happening. It was pneumonia, like a heart failure that's decompensated, sepsis. And these patients, like when they had really, really aggressive rate control, without like the appropriate like inotropic support, or like, maybe they weren't getting the antibiotics like quickly enough, or their lights weren't being repleted, whatever it might be, they ended up having like significant sort of like adverse events happen. And so most of this actually occur within the first hour or 2 hours within arrival when they received the rate control agents. More patients were intubated for hypoxemia from like their worsening sepsis. More people became hypotensive for kind of like rate control without like a clear idea. And this tended to happen with your patients who didn't really have heart rates above 150. But it can obviously be very, very muddled depending on the clinical picture and like how they look too. So obviously, like, you want to treat the patient and kind of their symptoms, but always kind of, be meditative, be thoughtful about what you're doing. And then the second article, it's just like a litany of many articles, many of the kind of papers showing that like you should be thoughtful about what you're doing, but cardioverting these patients might not be super effective either, actually, because these patients in this like second paper, they just went straight back into their rhythm, and more kind of like a workup and established that other things were going on as well. And then some people they don't really respond to cardioversion, which kind of goes against what we're, I think, typically taught with like ACLS. But you should start to think beyond ACLS when you manage these patients. So getting back to this patient here, right? I already kind of discussed they're super tachycardic. They're having an acute MI. Pulmonary edema is happening as well. So the critical action here, you should probably think about addressing the rate. You could theoretically make an argument that you might want to cardioverse this patient based on like your guidelines, right, from ACLS, and also just how they're looking. But their blood pressure is kind of maintaining, their oxygenation is improving with like supplementation. They're a little bit less altered and more conversant once you've kind of like treated some of these things. And so you could try, rate control for these patients too. We'll start off with cardioversion and kind of like the indications and what the evidence base actually shows. Your AHA guidelines that were published in 2019, they list cardioversion as like your grade 1C guideline. And you're supposed to cardivert patients who are unstable hemodynamically, patients who have myocardial ischemia, who have pulmonary edema. And the general idea is that, when you cardivert someone, you restore their hemodynamics, right? There's a decline in their LV performance and their function. And once you cardivert them, you return them back to their baseline. They've done a lot of outpatient studies on like your stable chronic AFib patients, and they've shown that your EF actually will improve. But that takes a little bit of time. And what's actually interesting is that there's some papers that actually show that you have a decrease in your cardiac output in that first week. Obviously, you can't really extrapolate outpatient studies that are done on chronic AFib patients to an acute care setting, but it's something to think about too, because you cardivert someone because you think it's going to increase their cardiac output, but it actually might not do that. And so you have to kind of weigh that as a pro and con as well. AFib with WPW is way more straightforward, really. You just like shock them until something happens that's good for the patient. Where they revert back to like a sinus rhythm, or they just have like a stable rhythm. Patients who rely on an atrial kick, we've already kind of discussed too, like they're very, very, very tenuous with their hemodynamics. And so these patients, it's more preferable to be aggressive. And then the last bit, which I didn't find a lot of evidence base to support this, but a lot of like ICU attendings have kind of talked to me about this, from Budarakis to Diaz across the street, a lot of different people, David Smith also, where you could consider using your bedside echo to help you make a decision to cardiovert. Obviously, this patient, you have a little bit of time if you're going to echo them and think about this kind of decision. So they might be the patients who kind of straddle this like border between driver versus passenger. And I think the idea is that, you want to see like a sufficient improvement in the stroke volume to outweigh the reduction you get in the heart rate once you cardiovert someone, right? And the tricky thing is that you don't really know what like the upper limit of the heart rate is, where, if you go too far, too high or too low, right? If this might cause the stroke volume to like, deteriorate or decline. And so this kind of varies between like patients, it's very independent, but in general, you can think about like echoing this patient. And if you see that they have like a pretty good EF, but they're just not really filling the ventricle at all, and so they have a pretty poor stroke volume, this patient probably, they're not really filling because of the tachycardia. And so you can consider shocking them because they might actually benefit from cardioversion here. On the contrast, right, if the echo shows like a pretty poor EF, but there's like decent filling in your LV, then they're probably unlikely to benefit from cardioversion. You might think about something else to do. Inotropic support, maybe they need pressors if they're hypotensive, something else that's like more advanced rather than just shocking them. But you can kind of echo them before you cardiovert and echo them after. And so if you're really like sort of like fluent with calculating BTIs and like doing all those things, you can actually see like a big difference post cardioversion if the intervention actually works for the patient. And obviously their hemodynamics should improve too, and their mental status, the clinical status should also improve as well. So that's kind of what we're taught, right? Like you cardiovert patients that are unstable, but the actual reality is that like the evidence base for cardioversion is actually very, very poor. And you see this in ICU patients often that are like critically ill, but you cardiovert them, they go into sinus rhythm, but then they go right back into like fib or flutter. It's rapid. This has been shown to be true in patients who have decompensated heart failure as well. And so it's just one of those things where like you do it, but then they just kind of go back into like their initial kind of like rhythm in their initial presentation. Especially for patients with chronic AFib, like cardioversion is less likely to maintain sinus rhythm. And so kind of keep that in mind. And if you're going to do it though, you should probably do it with like the maximum fixed energy. There were multiple kind of like studies done, both RCTs, single center and like multi-center RCTs that show it's better to actually like just go with like the high shock energy than doing like low escalating doses, because you have better success on like your first cardioversion attempt. You have better success in general at achieving sinus rhythm. And so it's better to just like go big. And then they've also done studies that show that there's no harm actually with shocking at the higher sort of like joules. You don't get like significant skin necrosis. There's no like further like troponin like leaks. There's no myocardial stunning or disruption that occurs. And so shocking with like a higher energy is actually preferable for these patients if you're going to do it. And then lastly, in terms of like the pad positioning, intro posterior seems to be probably like the best way to like capture enough of the myocardium, just because if the heart's fibrillating so much, it's kind of moving around everywhere really. And so you want to capture that. And you could consider actually putting the anterior pad more like right of like the sternal, lateral sternal border, since like you want to hit the atria. Yeah.
They talk about ablation for this patient at all?
It
seems like adding AFib is fast plus one right block.
Mm-hmm.
If you blade them, put it in a ventricle pacemaker, you might resynchronize them.
Yeah.
You might do a little bit better.
Yeah. So for this patient, they actually stabilized. They were admitted to the CCU. We'll get in the hospital course a little bit later, but it's more like a thing where they're kind of like elderly and family didn't want like too much care, just because it's going to be like too much intervention for the patient. But Dr. Silverberg is correct though. That's the ideal management course for that patient. Yeah. But if you're going to shock someone, like think about the pad positioning as well. And then we'll kind of like end with like a discussion on rate control. Once again, always consider like possible etiologies before you rate control someone, since there's a lot of evidence that shows rate controlling someone in critical illness has poor outcomes, possibly, if you're not like thoughtful about it. And so the idea of rate control really is you want to minimize symptoms, right? minimize pulmonary congestion, minimize palpitations, prevent tachycardia-induced cardiomyopathy. So that's kind of like what you want to do. And these are your guidelines for different rate control agents, right? Beta blockade is grade 1C, but it's really only supposed to be for people who are in rapid AFib, who don't display heart failure or any kind of instability. Amiodarone and digoxin have, 2B and then grade C evidence really. And they're recommended to actually be used in your patients with severe LV dysfunction or people that are unstable, but there's actually never been RCT done to support this. There are even fewer case reports on amio and digoxin compared to metoprolol and diltiazem actually. And funny enough, those two agents, you're told to not give them in this situation because there's this fear that you might worsen their hemodynamics significantly. And so the dogma really is that, you don't want to give cardizem, you don't want to give beta blockade. And this is all really founded upon these kind of post-MI studies that were done by cardiologists in the 1980s. They actually don't apply to these patients with AFib. But the idea was that you don't want a tachycardia after the MI because that's going to cause too much strain. And so they did various studies looking to see, if we give metoprolol, if we give diltiazem, right, to help prevent this from happening when they are tachycardic, maybe they'll prevent heart failure from happening. Maybe they'll prevent the patient from having adverse outcomes. And so what ends up being, done from these studies is that you have these adverse outcomes, but pretty much all of these things are referenced over the course of 12 to 52 months. So these are all chronic adverse effects with a mean duration over 25 months. So almost 2 years. So you're following these patients, you're giving them chronic, they're taking diltiazem or metoprolol orally over the course of years, right, to months. And so, that's kind of been extrapolated by cardiologists now to say that you can't really give these agents in the acute care setting because your patients with pulmonary edema, there might be too much mortality, morbidity. People with reduced EF, there might be too much morbidity. But applying this to the patient population, the specific case here, you can't really do that. It's not really an apples to apples comparison, really. The cohort with decompensated heart failure and rapid AFib, that's been excluded in pretty much all these studies. And so you're really extrapolating for something that hasn't really been studied extensively at all. And there's no head-to-head study comparing the use of beta blocker versus calcium channel blocker in your decompensated heart failure patient in a large, randomized controlled trial setting. And so your cardiology studies, they're evaluating the long-term effects of these agents in improving symptoms associated with systolic heart failure. But our goal is more to control rapid rate when that seems to be what's actually causing the pathophysiology, what's causing the patient to present in this extremis kind of fashion. So the pitfalls that occur here is that you're generalizing to the wrong patient cohort. These are adverse effects that are reported for long-term treatment really. And then the exclusions here are really the patients that we want to get more data on to kind of figure out how to manage them better, really, because this is what you end up seeing in the ED, right? And so think about that when you sort of contextualize the data and what cardiologists recommend. Obviously, these agents have their side effects, right? Hypotension, et cetera. But the evidence base is actually fairly minimal in supporting this. There actually have been all these small case studies and reports on cardizem specifically. It's obviously difficult to enroll since it's a very specific kind of patient presentation. But it's interesting because they seem to show that, cardizem has some beneficial effect when using in the acute treatment of atrial fibrillation with patients who have decompensated heart failure. And so both of these studies actually looked at patients who had heart failure with EF. It was grade 3, grade 4. So EF, with the median around 30, 35 range. And they're comparing cardizem in the first one to placebo. You're including people who have congestion on the X-ray or they're correctly on exam. And, their therapeutic response is to see if there's, rate control or a conversion to sinus rhythm. And your adverse events end up being, is this patient having hypertension that's developing that's symptomatic? Are they having an exacerbation of their CHF that's worsening their clinical status? And what's interesting to know, and these are obviously very, very small studies. You can't really extrapolate or use these to kind of form your entire clinical practice, but there's some pretty good outcomes here, actually. where you see significant symptomatic improvement and also rate control that's achieved. These are obviously uncontrolled small studies, but they do point towards some sort of benefit for cardism actually in this kind of like patient population. This was a larger retrospective study that was done, retrospective analysis in 2015, coming out of WashU, where they basically looked at all these patients who came in with heart failure in exacerbation, but also rapid AFib in exacerbation as well. So about like 200 patients split evenly between metoprolol and cardism. So patients were given IV push in the ED, and then they were admitted their rate control wasn't sufficient. And there was a pretty good efficacy with rate control. Metoprolol was a little bit better at converting the patient's sinus rhythm at 24 hours, but both were pretty effective in controlling the rate. And the patients actually tolerated the rate control fairly well. There wasn't like a significant like morbidity where they would go to the ICU later. They had like further management that needed to be done to diurese, to decongest, all those things. But there seems to be a signal towards some benefit in using these agents in like the acute care setting. This, once again, retrospective, small kind of like studies, observational, right? But it seems to be somewhat safe in using these agents for these patients. You can think about calling cardiology for these patients too, but it's really a bind where like, all the agents that you have available, they're not super great, really. Like giving someone digoxin, not super great. Starting someone on amio, terrible side effects, right? They all cause hypertension to some degree as well. Amio and digoxin, these medications have like really slow onset of action. Their side effect profile and the toxicity is quite significant. And they also don't really have RCTs either. There's obviously more kind of like clinical experience with using these drugs for these patients. But the evidence base also from meta-analyses, and this is mostly in like your chronic patients with chronic AFib, chronic heart failure, but digoxin has actually been shown to really have bad outcomes for patients, especially it's like with its poor therapeutic window and the toxicity that it occurs, that it accrues. And so, you can kind of like think about all these different things to do, but if your patient truly is having what you think is rate-related congestion, especially if it's like a rapid fib flutter, you could start off with a small bolus dose of your beta blocker or calcium channel blocker and have your other sort of adjuncts in place, but see how they do. And if they respond, that could be like a sign that you could kind of continue this in like a graded like fashion. This patient received Esmolol as a bolus and started on a drip. And so I thought that was a little bit interesting. And so looking into kind of like, the kinetics of it, right? The whole idea of starting Esmolol is that it's fast on, fast off. It's this cardioselective beta-1 blockade that occurs. And the way that you do it is you give this IV bolus, 500 micrograms per kg, and you start this infusion at 50 mics per kg per minute. And you let it go for about 5 minutes, and then you reassess the patient, look at the heart rate, see how they're doing. If they responded, but they're kind of going back up, then that's an indication where you might need to rebolus them again. And then you increase the rate up now to 100. And then you do this reassessment like multiple times, basically. It's a little bit tedious since you're bolusing and addressing like a rate, but it's good for this patient because they're tenuous and need to reevaluate their hemodynamics like fairly frequently. And so that's something where like you're at the bedside frequently, you can echo them, you can reevaluate how they're responding. If they're not responding, you can try other agents, but if they are, then you've seen something that might be, beneficial for this patient. It's interesting because in Japan, they've done all these studies for this specific ultra selective beta-1 blocker called Landiolol, which I've never seen here in the US. But like, it's like Esmolol, but like on steroids, where it's even more cardioselective. There's even less beta-2 activity. It has even less inotropic depression. And so they've actually done these studies where they found that it's fairly good agent in addressing this patient population who have heart failure that's an exacerbation and rapid AFib at the same time too. And so there's actually like an increased sort of interest in maybe trying to use Esmolol just because you've seen kind of these like small cohort studies in Japan for patients who have this beta blocker used as a drip in the management of AFib post-op, in the management of your AFib patients who haven't responded to amiodarone or digoxin. AFib patients that are hypotensive, that are on like milrinone or like dobutamine, but they're still rapid, right? They're using this medication to like pretty significant effect. And so we don't have this here in the US, but it's becoming more kind of prevalent in Europe too. So think about this maybe down the line, but this is going to prompt more research into Esmolol being used for this kind of patient population. And so for this patient on their inpatient course, so hospital day 1, they were started on insulin drip for like a mild DKA. Hospital day 2, the rate control was kind of established, and they transitioned from Esmolol to like a PO medication. So in this case, it was Amiodarone. Hospital day 3, they had an echo done that showed an EF of 20%, large anterior wall motion abnormality. You see that there's a troponin trend that's downtrending. It's like 27, that was the last one that they got. And so this patient was started on goal-directed medical therapy. So metoprolol, Entresto, aspirin, Plavix. They continued on amiodarone. And then they were downgraded to floor in hospital day 8. Over the course of their stay, they would kind of go into this like rapid AFib, would respond to like IV push metoprolol basically, and go back into like normal sinus rhythm or just like in an AFib that's rate controlled. Eventually they dropped their hemoglobin for unknown reasons. So the medicine called GI, who said nothing to do for this patient who just wants kind of comfort care and just kind of like, no intervention. And so they transfused the patient unit, beheld the antiplatelet agents just for like a couple of days. And then eventually they discharged this patient back to a subacute rehab before they went home to kind of like rest. And so the takeaways that I got from like doing this research and kind of like thinking about this talk was that, rapid AFib and rapid AF flutter, it acutely impacts diastole specifically. And so think about that and how it informs like your decision-making process. Always think about the structural states that rely on your atrial kick for like the cardiac output. So diastolic dysfunction on patients with rapid fib flutter, stenosis of the valves, pulmonary hypertension and right ventricular dysfunction, because they warrant more aggressive treatment. As always think about what's driving the instability, and you always want to evaluate for the underlying etiology, right? Like, is this withdrawal that's causing the patient going to like rapid AFib? Are they having a PE? Are they septic? Are they GI bleeding? Or is it just kind of their flutter or fib that's uncontrolled, basically? And so, cardioversion in general doesn't seem to work too much for like your chronic, like sick patients, but if it's going to work, it's going to be for someone who's very fast. You could consider using like, slow IV bolus of Diltiazem, just to see how it works. Have all your adjuncts ready. Think about maybe starting pressors if you need to, but if it ends up helping to reduce kind of like this rate so that the patient can have more time to fill their ventricle, they restore their atrial kick to some degree, then you've actually kind of found the answer for this patient. And you can always consider using Esmolol since it's a quick on, quick off agent, especially if like, amio or digoxin isn't something that you're really considering for this patient. Here's some of my references. And that's pretty much it.